Hi, everyone. My name is Laura Wagner, and I'm a professor at the University of California, San Francisco School of Nursing. And I am leading the webinar today. Dr. Frogner is unavailable, and so I will be moderating today's wonderful session. Our session today is going to focus on the Award Network Fellows findings. And today we are pleased to have Alfred Boakye from the University of Maryland and Alexandra Lovett from Emory University presenting that. And if you have any future ideas for webinars, please use the QR code in the corner to submit your ideas for the webinar committee. So our next webinar will be on June 4th. It will be titled The Buddhist Contribution to Dementia Care by Henry Hsu, Dr. Henry Hsu from the University of Toronto. The webinar committee members are Dr. Bianca Frogner, who is leading the webinar committee. Then we have Megan Gatley, Roy Thompson, Jin Jun, Kira Riskina, and Kate Brown. So thank you to all of the webinar committee members who are part of this wonderful opportunity to disseminate the work of the Award Network. Our leadership committee is Dr. Joanne Spetz, Dr. Susan Chapman, myself, Dr. Kezia Scales, and Dr. Bianca Frogner. And I just wanted to acknowledge our funding. We are funded by the National Institute on Aging. This is an R24 grant, and the views expressed in the presented materials don't necessarily reflect the official policies of the Department of Health and Human Services or the National Institutes on Aging. And so I will stop sharing. And I will next introduce my speakers. The first speaker will be Alfred Boakye. Alfred Boakye is a doctoral student in gerontology at the University of Maryland, Baltimore, and Baltimore County, UMB, UMBC. Mr. Boakye holds a master's degree in gerontology from Georgia State University and human resource management from the University of Ghana, Accra. His research explores the interplay between trauma and resilience among minority direct care workers who are Black, Indigenous, and persons of color, and examines how their experiences shape the care and support provided to people living with dementia. Mr. Boakye's work seeks to develop innovative strategies that empower direct care workers to improve their health outcomes, enhance care delivery, enabling them to provide person-centered care to nursing home residents with dementia. Alfred's presentation title is Assessment of Trauma-Informed Coping Strategies Among Direct Care Workers of People Living with Dementia in Baltimore, Maryland. Alfred, thank you for attending and looking forward to your presentation.
Thank you so much. Thank you so much for the introduction. Can you all hear me?
Yes.
Okay, so I'll go ahead and then share my screen. Mm, mm, Let me see. Can you see my screen now?
Yes.
Perfect. Okay, so thank you so much for that introduction, and thank you for the opportunity to present something of the progress on the work that I've been doing since I got selected for the Award Network Fellowship grants. And so today my presentation is titled Assessment of Trauma-Informed Coping Strategies Among Direct Care Workers of People Living with Dementia in Baltimore, Maryland. And my mentors are Dr. Nancy Kussmaul from the University of Maryland, Baltimore County, and Dr. Jennifer Kraft Morgan from Georgia State University. So I want to say a big thank you again to Advancing Workforce Analysis and Research for Dementia Network Research Fellowship Program for supporting emerging researchers to advance their research on healthcare workforce that serves people living with dementia. And I also want to use this opportunity to thank my mentors for supporting me in this project. So this will be my presentation outline, an introduction, my research aim, methods, challenges, and some next steps. So I want to share that I'm still working on this project, and so I'll share where I've gotten to so far and then what I plan to do in the coming weeks and months. So we know that the US population is aging and we have higher prevalence of dementia, um, either in nursing homes or assisted living or in their private homes or other healthcare settings. And the role of direct care workers is very, very essential because they are able to help support people living with dementia. And as care partners, we know that they make up 1/3 of the healthcare workforce in the US, and it's projected to grow. And so, as at 2015, it was about 3.4 million, and sorry, it's actually growing by 48%. And so by 2030, we are looking forward to adding over 800,000 workers to support older adults because according to reports, by 2032, and for the first time in the history of the United States, those or older adults 65 and older or people 65 and older will outnumber those 18 and below, which means that it is critical we pay attention to the direct care workforce that provides support to older adults. And in providing support to older adults in various long-term care services and support. So whether nursing homes, assisted living communities, or home care, as well as other healthcare settings. And so before I go to the state of the direct care workforce, I know I'll be going to some challenges, but last month, I saw a report by USC Leonard D. Schaffer Institute for Public Policy and Government Services, reporting the cost of dementia in the US as of 2025, and reported that about $8 billion goes into care partners either leaving their jobs or cutting back, as well as $302 billion going into quality of life, quality of care loss for dementia and people living with dementia and their care partners. And so this is it's very, very informative. It tells us the state of dementia prevalence and the adverse negative impact or the adverse impact of dementia on people living with of the US population and their care partners. So with my research interest, I have come to realize that the direct care workforce is mostly or predominantly women and people who are Black, Indigenous, and people of color. And these people experience high emotional stress throughout their work. Unfortunately, they do not receive huge sums of money, or they have low pay, which kind of also affects them. And there's also high risk of infection in these various healthcare settings. Unfortunately, they have either limited paid sick leave or it seems non-existent in some healthcare settings. And all these things is leading to high rate of depression, burnout, anxiety, and post-traumatic stress disorders for direct care workers, ultimately reducing their quality of life. And so it is important that we design programs that can support these direct care workers to navigate the challenges that they experience and to build resilience. And building of my work and within the larger framework, the 2020 National Research Summit on Care Services and Support for Persons with Dementia had research goals. And one of them was to develop and evaluate training for direct care workers to identify competencies and modalities, and also to help improve health, quality of life, and financial and social outcomes, as well for persons living with dementia their care partners, as well as direct care workers themselves. And once we are able to build these training modalities, then we are able to help improve the quality of life, because then we'll be able to design competency-based approaches and competency-based trainings, which seem non-existent. And so my broader aim is to investigate existing resources, either at the personal or organizational level, to optimize the work of direct care workers in nursing homes. More specifically, I want to understand direct care workers' knowledge and attitudes about trauma-informed approaches and dementia care in nursing homes, and then assess existing coping strategies among these direct care workers in nursing homes who provide dementia care, so that it will tailor into these trainings to build their skills and competencies. So my methodology. So I had to write an IRB, and so I got IRB approval from UMBC's Institutional Review Board, and I plan to interview CNA. I plan to collect survey data from CNAs in nursing homes. I am targeting 100 CNAs in 2 to 4 nursing homes in Maryland. And my procedures, I have sent out site letters and letters of agreement, informed consent. I have designed a short, de-identifiable demographic information. And initially, the plan was to do a pencil and paper survey, which I'm going to talk more about in my subsequent slides. And it's supposed to take about 10 to 20 minutes to fill this survey. And you have unique IDs to kind of help with coding, but not necessarily linking any participants to their responses. And then we estimate to compensate them with a $10 gift card. And I conducted a pilot study with 10 students from my department, just to help with comprehension and time in filling out the survey, so that we don't experience burden when these participants burden when they are filling out the surveys. And so these are the measures that I am using. And so first, I want to understand their knowledge, attitudes, and practice. And so I'm using the knowledge, attitude, and practice scale by King et al. 2019 to assess their knowledge and skills and practice of trauma-informed care through an interdisciplinary approach. And then I'm using the trauma-informed climate scale by Hills et al. 2019, which I'm fortunate one of my mentors, Dr. Nancy Kusmo, was part of that team to work on that scale. And it's to measure staff perceptions of their work environment and how it impacts their work and health. And then also the job stress scale by Parker and Decotes to determine the factors that lead to burnout and reduce self-care among direct care workers. And then use the problem coping mode scale to assess coping strategies to promote positive attitudes. And this scale actually measures problem-solving skills, emotion regulation, religious practices, fantastical thinking, and also social support streams. And then finally, the organizational commitment scale by Allen and Meyer, the revised version, is to help understand the nature, antecedents, and the consequences of staff commitment towards health promotion. It is important that we understand that connection, because it is one thing creating those modalities, creating those trainings, building those competencies, and also another thing where we have employees committed. And tied to my larger or my overarching goal for my dissertation, I want to understand trauma-informed approaches and trauma-informed care among these direct care workers, just thinking about how psychological safety impacts performance among these care workers. And so it is important that we draw that connection to how committed these direct care workers will be based on whatever is happening within their work environment. So I want to highlight some challenges that I've faced so far, even though I have received IRB approval. It's been difficult recruiting nursing homes to participate in the survey or in the research. And so unfortunately, I will not be able to present results or findings, but I believe these challenges are also key findings because then it will help to enhance our discussions and then also solicit your views and your suggestions on the best approaches. And so I have I wrote to 4 nursing homes. I have followed up with several emails, but I have not still gotten any feedback. But and so then what next? Well, I had a meeting with my mentors and we decided that we were moving the survey to provide an online version. And so I had to amend the IRB to include online survey and an online survey component. And I resubmitted it just yesterday. And so I'm hoping that by end of this week or next week, we'll get approval and from the IRB, and then we can start collecting the data from online. And we also have some contact persons with the National Association of Nurse CNAs, and we are hoping to reach out to them to see how they can help us to collect data for this research. And so here are some references, and thank you for your attention, and I am open to any suggestions or ideas to move this work forward. Thank you so much.
Thank you. That was great. This is my population, so I'm particularly interested in hearing how you just it's so difficult to recruit direct care workers and especially to talk about sensitive information. So I'm just
Mhm.
wondering how do you build rapport with the facilities and with your potential participants?
Okay. Yeah, so in terms of building rapport, so I moved from Georgia to Maryland, and so I'm now trying to establish relationship in within the Maryland space. But my professors have also been helpful because they have some research connected to nursing homes, and so they have also sent words out to see if we can recruit other direct care workers from these nursing homes. But we want to use the virtual or the online survey version just to complement, just in case we still do not get any feedback from these nursing homes. But our survey is tailored in such a way that we have parameters and checks to make sure that they work within Maryland and not just anybody working or any CNA, sorry, working um, across the US. Yeah.
And what's the best strategies that you've found in getting facilities to respond?
Okay, so I think going there in person kind of worked because I spent my spring break, my entire spring break, following up on administrators and director of nursing in these identified nursing homes. I was getting feedback. They were reaching out to me to make sure that the direct care workers in these nursing homes were not going to be exposed. Just as you rightly said, the topic is very sensitive, and so
Mhm.
they really wanted to protect the staff. And so I assured them, and then I sent them all the protocols in terms of the IRB, the informed consent, all those materials, just to let them know that it's going to be conducted in a very, very confidential way. But I don't know if it's the upper levels or I don't know what's going on, but I'm still following up on them and still trying to provide the online version as well.
Yeah, and that was my next question, and maybe I'll come back to talking a little bit more about that. Have you found a difference in just re recruitment and response, whether they're going to be completing something on a web version survey or paper pencil.
Yeah. So um I don't know if I got that question right, but for if we are able to recruit from the nursing home physically or in person, then they will fill the paper and pencil survey.
Yeah.
But if we go through um, organizations, and then we might use the web-based approach.
Got it. So this is still a little bit of a work in progress on what would be
Yes.
the best strategy. Yeah,
Yeah.
I've had success with both options
Mm,
and challenges as well. So I'm really interested in hearing how this all plays out for you.
yeah.
Um, and have you thought about building trust, like as a researcher doing this research with this population? What are ways that you build rapport and trust with the facilities? And I realize you said you're new to the area, but in general, how do you build trust with the groups that you're working with?
Um, well, in building trust, I think it's about making them feel safe to a large extent, because on a different project, for my GRA, we also go into nursing homes. We are doing a palliative care project where I go in to collect staff surveys and all that. But then most often than not, sometimes they are very open to with me. They tell me what their challenges are, and I keep assuring them that I totally understand what they are going through. I totally understand the complexities with their care, with the care that they provide. But I am also proud of them because they have built resilience. And just reflecting on my master's thesis, interviewing CNAs and understanding the trauma that they go through and how they still have to come back to work. I think it's just giving them that ear, that listening ear, that they know that somebody understands what they go through and the kind of work that they are doing, and ultimately how it's going to positively impact care recipients. And so most often, I don't know if I'm answering the question, but
No.
I try to be flexible with them. I try
Mhm.
to smile. I try to approach them in a nice way because I understand what they go through, because I've been to a couple of nursing homes and I see what they do. So
Yeah, and how important do you think that is, just having that understanding? Because there are some researchers who haven't had the experience as a certified nursing assistant or that direct care worker experience. So, what would you recommend for researchers who haven't had that lived experience in ways to get to know their population?
yeah, I think it will be very, very important to um, observe, because going through nursing homes, it's actually really helped me with my own reflexivity, because then it helps me to think about, okay, when I was growing up, I worked in a factory where we face very harsh working conditions. And so it kind of shapes how I will interpret the
Mhm.
information and or the data that I collect. And so I would highly recommend that every researcher who is interested in direct care work, who is interested in nursing home research or assisted living or home care work, whichever long-term service and support setting, they should at least go and observe
Mhm.
what is going on so that they can report, because it's different reporting when you have no information than reporting when you have information. And that was perfectly my experience, because as an international student coming from a country where we do not have nursing homes,
Mhm.
and then I want to do nursing home research, and I just couldn't connect the dots. until I went to one nursing home to intern with them. So I was an intern for a couple of months before I collected my data. And this really shaped my thinking and my approach to the direct care research. And so I think it's important that they gain that experience.
Well, Alfred, we are so fortunate to have you as part of our team and in doing this type of research. So I'm glad that you had that experience. There was one comment
Mm,
from somebody in the webinar group here said, I recommend recruitment via in-person presentation with the nursing home staff.
mm,
But before that, upper level leadership and director of nursing supervisors also need to approve.
mhm,
And I'm sure you've had to deal with that. But this helps to build the trust when you're doing that in-person works, other than just sending it out an email or sending out a flyer, for example. So that in-person connection is really important.
mm.
Dr. Scales, did you have a question?
Sorry, I was actually just trying to applaud
Oh,
via via Zoom. I really appreciated that presentation, and since I'm off mute now, I will just really underscore. I think it was so the content you shared afterwards, Alfred, about how to build trust and understand the context in which you're
Mhm,
trying to collect data is so important. And I think it cannot be the value of spending some time, whether, you said as an intern or even shadowing for a couple of days, but the value of spending some sustained time in these environments and kind of understanding um, what goes on behind the curtain that we're trying to peek
mm,
behind when we're doing the research, but to get a better, sort of more well-rounded understanding, I think really helps so much as you're thinking about the items in your surveys and how to reach the CNAs or others that you're trying to reach, and how to interpret the findings and how to present them back to those who are offering up these insights. I just
mhm,
think understanding the context is so important.
mm.
Thank you.
Thank you
thank
so
you.
much.
Well, thank you. We're going to shift now to our next speaker. So thank you again, Alfred. And
Thank you so
Alfred
much.
will be available if we have questions. Time at the end, we can ask more questions. All right. So our next speaker is Alexandra Lovett. Alexandra is an MD, PhD student finishing her second year of the doctoral program in the Department of Epidemiology at Emory Rollins School of Public Health. She envisions a career as a physician scientist using mixed methods to inform interventions that improve outcomes for dementia patients. Her contact with patients as a clinician will enlighten her research questions. As an academic, she will produce rigorous work with actionable recommendations for policy and local interventions. I love this ambitious career goal of yours, Alexandra. This is really great. Alexandra's presentation title is Availability of Adult Day Services for Hispanic Older Adults. Thank you, Alexandra, for sharing your findings with us today.
Thank you for the opportunity. Can you hear me okay? Okay, let me. Okay, so my advisor is Dr. Regina Shi, and I'm very grateful for the opportunity to present this work, and it is also a work in progress. By the end of my talk, I want some advice on data sets with larger samples of Hispanics in adult day services and feedback on interview questions with caregivers and ADS staff that could fill gaps in our understanding of the needs of Hispanics in adult day services. So to start off with some background, adult day services is at the intersection of long-term care and home and community-based services. They offer daytime social and medical care to improve the quality of life of participants and also provide respite for family caregivers. There is a lot of variability in services and staffing models, and centers are usually staffed with registered nurses, licensed practical nurses, nursing aides, social workers, activity professionals, and occupational and physical therapists. Some centers are faith-based, and some are community-based, and others are licensed centers. And the availability of data on these centers varies by type of center and area of the country significantly. ADS participants are the most diverse of those in long-term care, with Hispanics being the largest minority group. And in 2019, the US had 4.6 million Hispanic older adults, and the census projects that number will grow rapidly to 19.9 million by 2060. The US has a rapidly growing population of Hispanic older adults, and serving this growing population requires culturally aligned care, which in turn requires an increase in adult day centers and effective training of those adult day services workers in the regions of high growth. So the aims for my project were, one, to map the availability of adult day centers with growth of Hispanic older adults to identify areas that have scarcity of adult day centers, describe the health patterns of Hispanic participants with Alzheimer's disease in comparison to non-Hispanic participants with Alzheimer's disease, and then to elucidate the Hispanic experience in adult day centers through interviews, including how staff deliver dementia care and meet the need of family caregivers. So starting with aim 1, we mapped using census data from 2010 and 2020, and we calculated the percent growth of Hispanic older adults age 65 or older, and mapped the counties by the percent growth, and then used the National Association of Adult Day Services locator to gather a list of addresses of adult day centers. And that gave us an N of 386 adult day centers nationally. Here, to start us off with some context, I've mapped the net gain of Hispanic individuals from 2010 to 2020. Darker areas had a larger positive difference in number of Hispanics between 2010 and 2020. Dark blue is more than 5,000 Hispanic older adults gained. And as expected, the urban areas have large gains, especially Los Angeles, Las Vegas, Miami, New York City, and Chicago between 2010 and 2020. And then when we overlay the adult day centers, it follows a similar pattern with more centers over urban areas, and some areas having mid-range gain of Hispanic individuals did not have as many ADS centers. If we zoom into the Southeast, as an example, South Florida and Central Florida had large gains in Hispanic individuals with few NADSA affiliated centers. Miami-Dade County down here had a gain of 80,000 Hispanic older adults, and Broward County 37,000 with very few adult day centers. Similar for Orange County, which is where Orlando is, with 21,000 net gain of Hispanic older adults and very few adult day centers. Gwinnett had a more modest gain. It's a suburb of Atlanta, 5,000 additional Hispanic older adults. Charlotte was similar, and very few adult day centers. DC itself had mid-range shades of blue, which is difficult to see here because of the sizing of the map, but the surrounding counties are actually the ones that are dark blue, and those had actually decent coverage of adult day centers. Then we wanted to look by percent growth of Hispanic older adults. The percent growth in Hispanic older adults reflects counties whose demographics are changing quickly and whose needs for workforce and adult day centers will change quickly as well. Most of the counties that had more than a 300% increase in Hispanic older adults are rural, which are these dark blue shade. But of note, this mid shade of blue is still quite large percent growth of Hispanics because these populations are more than doubling. Many counties more than doubled their Hispanic older population, including, again, the urban centers on the East Coast of Boston, Philadelphia, Atlanta, Charlotte, Nashville, and also on the West Coast, like Vegas and Portland and Seattle. When we overlay the adult day centers, the number of adult day centers did not offer good coverage for many areas with high Hispanic growth. Again, zooming into the Southeast, many counties were more than doubling their Hispanic population, including urban centers and rural areas. In Georgia, the counties that include Atlanta and all of these surrounding suburbs more than doubled their Hispanic older population growth and had minimal ADS centers. Savannah and Charleston were very similar, And South Florida, which earlier we saw had high number of just net individuals gained, had less population growth as a percentage. So some takeaways from our first aim with mapping was that areas with high percent growth of Hispanic older adults did not have good ADS coverage. And one of the limitations to this mapping is that there is no nationally comprehensive list of ADS centers, in part because of that vast heterogeneity in types of centers and how states gather that data. Some states do have more comprehensive lists of adult day centers. So future analyses could zoom in on one state, one area, and see what the changes are there. And that would more likely include non-NADSA affiliated centers and be more comprehensive for one state. In aim 2, I wanted to describe the health patterns of Hispanics with Alzheimer's and in comparison to non-Hispanic participants with Alzheimer's. We plan to triangulate the CDC's NPALS public data release with NADSA data. NPALS is a national data set for long-term care services that includes adult day centers, and they have a specific data set to just adult day centers. And they collect the data directly from adult day services center directors and sample 2 adult day service participants from a randomly selected sample of eligible centers. NADSA is a private data set that gathers more specific outcomes data through convenience sampling of affiliated centers. When we looked at the NPALS 2022 dataset release, which happened just last year, the Hispanics who participated in the survey gave us an N of 62, which was about 14% of the sample. And then Hispanics with Alzheimer's was just 16. So that gave us very scant data on Hispanics with dementia. And this was unexpected considering the growing number of Hispanics throughout the country and larger numbers of Hispanics in previous data releases. In 2022, looking at the documentation, 60% of adult day services centers that were randomly selected for survey could not be contacted. So they were therefore not included in the sample. So that might explain the small N overall, but also the small N with Hispanics. So we turned to the NADSA data set, and this one, we had a data poll with participants that had ethnicity and primary language data. The data was collected from 2023 to 2025, and the data collection is still ongoing. The data set includes centers from Georgia, Indiana, Michigan, New Mexico, New York, and Tennessee. And then we were going to focus on these 2 exposures of ethnicity and primary language. When we looked at the ethnicity variable, there was a mix of responses that included race, ethnicity, and country of origin. And we were able to recode that in this way, but after some recoding, we had 803 people that were unknown. So Hispanic included Latino, Dominican, Puerto Rican, Bolivian, Mexican, Salvadorans, in addition to those who had been labeled as Hispanic, while unknown included American, Italians, Bahamian, English, French, Indians, Irish, Jamaicans, and unknown. American had an N of 401, so a large portion of the sample was labeled as American, and it's unclear whether they were white, Hispanic, or what origins they have. So limitations is that there were no multi-race options. So all of these were mutually exclusive. And then the mix of race, ethnicity, country of origin, or maybe even nationality that we aren't sure how to encode. So we need more time to decide whether and how to encode these responses accurately. Primary language was more consistently measured. So the responses here were English, Spanish, mainly Armenian, Japanese, Korean, and other. There were 53 respondents who said they spoke Spanish as a primary language, which was 5% of the sample. Of the 53, 48 of those adult day service participants were in Indiana. And the low power, again, really limited our analysis, and we considered this wouldn't be a representative sample, considering almost all of the Spanish-speaking respondents were from NADSA-affiliated centers in Indiana. So we had some strengths and limitations for NADSA and NPALS. Both NPALS 2022 and NADSA had a limited N for Hispanics. And then the NADSA data detailed information on nationalities and language preferences, which could yield really interesting analyses, but the N is not large enough. So as the NADSA data collection continues and that power grows, then maybe the NADSA data set could fill very important research gaps. The limited samples then motivated us to look at NPALS 2018, which seems to have been more successful in their random selection of centers because they had a non-response rate of 33% rather than the 60% in 2022. NPALS 2018 includes the outcomes measures of difficulty with memory, communication, and behavioral symptoms. So overall, these were some of the stats in this sample, with 16.1% of adult day services in the NPALS sample being Hispanic. In Alzheimer's versus no Alzheimer's, there were differences by age, sex, and race, and those with asterisks are p-value less than 0.05. And then when we looked at memory, communication, and behavioral symptoms, we found that those with Alzheimer's had more difficulty with memory, more difficulty with communication, and less presence of behavioral symptoms. And in part, we think this might be a selection bias being reflected where adult day centers are not managing to retain or enroll Alzheimer's participants that have both behavioral symptoms and memory difficulty. In particular, because that's a workforce challenge, providing care for those patients. This suggests that ADS may be less inclusive of Alzheimer's patients with both behavioral symptoms and memory difficulties, which could be an opportunity for workforce training and supports. When we looked at non-Hispanic Alzheimer's versus Hispanic with Alzheimer's, our N again got really small with only 34 Hispanics with Alzheimer's in this sample. And we did not find a significant difference in difficulty with memory or difficulty with communication or behavioral symptoms present, but this is likely driven by just lack of power and how small the sample of Hispanics with Alzheimer's is. So some takeaways from my second aim of seeing the health patterns. The limitations were that this is an unadjusted bivariate descriptive data. There are no statistically significant differences in outcomes by Hispanic among people with dementia, and probably because of the insufficient sample size, which leaves some looming questions of how do people with dementia with behavioral symptoms access adult day services? How can adult day services staff receive better supports to manage behavioral symptoms of dementia? And are there differences in needs for people who are Hispanic with dementia? So if anyone knows of other data sets with sufficient sample size, even if they're more concentrated to just a county or just a state, more regional, I think that would be really helpful in seeing any disparities that are specific to Hispanics. And then aim 3 became all the more important, which was our interviews with workforce and caregivers. So for the interviews with the workforce, we plan on recruiting from 2 to 3 centers through convenience sampling. And we're focusing on centers in counties with moderate to high percent Hispanic growth per our mapping data. We plan to precede the interviews with a discussion with center directors to get some context on the care model at that center and some of the staffing roles there, since the centers do vary so much. And then we want about 10 interviews with center staff that have served Hispanic older adults with dementia. And we're going to ask them about demographic information, including their job title, ethnicity, and languages spoken, description of experiences serving Hispanic populations, including narratives of successful encounters and challenges, and then changes that would improve the workforce experience in caring for Hispanic participants in adult day services. We are also going to conduct key informant interviews with caregivers, again, about 10 interviews. And they will be caregivers of Hispanic adult day service participants with dementia. Recruitment from the same centers as the workforce through snowball sampling, and then we'll gather demographic information of the participants and the caregiver, what the participants' enrollment experience was like, and the participants' experiences while in adult day services, and then the impact the service has had on the caregiver and their relationship with the participant. So our next steps will be finalizing these interview questions, which we appreciate y'all's expertise and feedback on, and recruitment over the summer, and then interviews on a rolling basis for analyses in August. So here are some conclusions. For AIM 1, which was the mapping aim, we had counties with high Hispanic older adult percent growth were often areas of ADS scarcity, and the changing demographics can indicate areas of changing needs for culturally informed care. And next steps will be to do county level projections of Hispanic older adults with dementia. For the health patterns, management of behavioral symptoms among Alzheimer's ADS participants may be a workforce training opportunity. And then analysis of Hispanics with dementia and ADS was limited by low power. So our next step will be identifying those data sets with larger Hispanic participants. And then for qualitative, like I just said, we will be conducting interviews with the staff and caregivers to fill the gaps that the quantitative analysis left. I'd like to acknowledge the award network for this opportunity and the funding to do this research, my advisor, Dr. Regina Shi, for all her guidance, Director Zargorski, which is a board chair of the NASA Center and has been instrumental in giving us feedback for the questions and recruitment strategies, and Dr. Tina Satarangani, who also helped with both the proposal and our interview questions.
Great. Thank you for sharing. Feel free to put some questions in the Q&A forum. Well, there is one question about NPALS. Is it possible to pool multiple years of data with NPALS?
That is something I hadn't considered. I think one of the challenges would be that certain years are encoded differently. So how would I combine multiple years? Yeah, I'm not sure. The public releases are every 4 years, so they're not that frequent anyway.
And I would suspect that the trends are going to only increase from here. So 2018 data is fairly old at this point on just the percentage of the aging Hispanic population. Have you thought about is there a direction, just a shift in care where traditionally certain cultures care for their loved ones in the home, and now here we're introducing in a setting that is outside of the home, and I'm just wondering if you've given some thoughts on how that is contributing to the low end, or are we going to be experiencing a shift in care?
Yeah, I think in part there is that cultural difference where maybe we don't know this, but maybe Hispanic individuals have a preference for caring for people at home. But the other limitation is that maybe they are more inclined to enroll in more community-based or faith-based centers that aren't captured well in this sample. So that's the other question. Are they flocking to other centers? But my inkling is that at a certain point, because of the needs for caregiver respite and the burden of caring for someone with severe dementia on the family, they do turn to adult day services or other services that would help them. The question is, how do we get a good enough data source to capture the adult day services or any other service that they are using? What are those services?
Mm-hmm. Great. There's a question from one of the panelists. It sounds like you wanted some feedback on your third AIM interview questions. Is that, could you say more about what types of questions you're considering and what kind of feedback would be helpful to the Award Network attendees?
I think since the Award Network focuses on workforce, what questions would be helpful in terms of workforce needs or would be productive, especially. I think it's hard because the adult day services centers vary so much to know what questions to ask, and the role of a nurse versus a physical therapist they're very different. So what questions would be most helpful? Would it be better to focus in on just one of those job titles or keep it open? Just any feedback on that front, I think would be really helpful.
And have you given some thought on just culturally considerations around, let's say we have an adult day health center that has, I know, and one that actually I've taken students to, they had a group for people with early stages of dementia that only spoke Spanish, and they had, a caregiver working with that group specifically. So I'm just, there's opportunities here in thinking about how we develop different models of care for this population.
Right. I think that's where the discussion with the center directors comes in because I obviously would want to know if that's what's happening. And then that's another question of should we prioritize centers that don't have that model of care to identify then the needs in training, prior to getting that role? Or should we prioritize centers that already have some infrastructure for Hispanic or Spanish speaking participants and see how they're doing and what is going well in that scenario?
And given that you're really interested in the policy implications of this, what would be some policy implications on increasing funding or like how does that work? Can you tell me more about your thoughts?
I
Because given your
I
interest.
think I think first some more standardized definitions of adult day services on a national scale and more like cohesive data collection on a national level,
Mhm.
since we are missing a lot of centers in this list. And then from a policy perspective, I think prioritizing areas that have large demographic changes and like percent growth
Mhm.
to really prioritize that cultural training and how are we going to meet these needs and kind of as a way of getting ahead of the ball because right now I think the population drastically changes. We have large numbers, large demand, and then things change. And I wonder from a policy perspective, we could incentivize um, these percent growth areas are rapidly changing, and we know that. So, can we already incentivize some training in these states prior?
Yeah, I think that's one of the questions that Dr. Frogner's had, some feedback about your third aim is just looking at these areas of growth, especially in rural areas. How do we find bilingual providers? How do we go about, recruiting those folks into this area? So that certainly can be an implication just around recruitment and retention, but just getting them there to begin with.
Right.
Are there any questions we have just a few minutes left. Yeah, and certainly, cultural competency is important. Making sure that's
Mhm.
built into curriculums for training. And I just really see that your work, Alexandra, is just, I think you're ahead of the game here, and this is great to start getting all of these ideas, especially with adult day centers and the increasing diversity of our older adult population. Just really excited about the work that you're doing to get us off to a head start on this, and especially in those areas of growth. Was really intrigued by the maps that you shared with us.
Thank you. I appreciate it because it has been challenging.
Yeah, I can imagine. Yes, just keep showing those trends, I think is really important. Alfred, I don't know if you want to turn your camera back on. We just have 1 minute left. I just want to thank both of you for coming today, for presenting your work. This is really, really inspiring to see the future of the work that you're doing with the workforce of people living with dementia. And I think just the importance of qualitative work as well, in the work that you're doing really speaks, those stories, those experiences, those examples are what's going to help sometimes drive some of those policy changes. So don't forget about the importance of that work as well. And we just have a lot of, accolades and great presentation comments coming through. So, uh, just want to thank everybody for coming. And One final plug, I did not mention this earlier, given I was having some IT challenges, is tomorrow you're going to be receiving an email that the National Dementia Workforce Survey Wave 3 feedback on the survey content, some information about that's going to be coming out. So look in your inboxes tomorrow for that email, and we look forward to getting some feedback about the Wave 3 survey. So thank you, everybody, for coming. Great job, and we'll see you next month.